Now, our first speaker, Dr. Tamara Nation, Gut Health for Developing Minds and Bodies. After graduating from the University of Melbourne Medical School, Tamara worked at St Vincent's and then at the Royal Children's Hospital. She also completed a PhD at the Murdoch Children's Research Institute, further developing her special interest in paediatrics. Tamara then undertook training as a GP and became a fellow of the RAC GP. Her special interests, and she have many, but some of them include paediatrics, childhood, immunisation, adolescent health issues, women's health, gut health, and the microbiome. Over to Tamara.
Thanks, Christine, and thanks everyone for coming in tonight to listen to us talk. I'd like to kick off the evening discussing the development of the microbiome in the paediatric population, starting from preconception through to early childhood. So microbes and the existence of microbes were suspected in ancient times, first documented in Jain scriptures in the 6th century BC in India. They're unicellular organisms and they live in almost every habitat in the world and outer space as well, as recently they've been discovered in Mars. The gut microbiome, this includes trillions of microbes which inhabit the gut. They form a complex relationship with their human host, ranging from a symbiotic to pathogenic complex. They're affected by multiple parameters in the environment, including pH, oxygen levels, nutrient availability, hydration, temperature. And this leads to various populations thriving and others declining. One of the key functions of the microbiota and the biome is the digestion and absorption of nutrients and the excretion of waste. Apart from this digestive process, there are many other roles that the microbiome plays. And that's a role in activating immune defences and immune tolerance. It's also been associated with gut-brain communication and the mood and pain responses. The first 3 years of life are critical to the development of the biome. In the first stage, from conception to 12 months, it's a key phase where fundamental phyla and species are embedded in the gut. In the second phase, from 12 months to 3 years, the biome can transition in terms of diversity and density. And then beyond 3 years, in early childhood, it's relatively stable, similar to an adult biome. There are many influences on this diversity and density in the gut. The way a baby is delivered, the gestational age at delivery, neonatal and infant infections, first foods and feeds, antibiotic and pharmacotherapy use, as well as genetics, immune function, and maternal factors. So it all begins with mum. Until recently, the fetal environment was thought to be sterile. However, we now have other hypotheses which discuss the colonisation in utero. And this may occur from microbiota ascending from the maternal vagina. Also, it may occur via maternal dendritic cells that sample bacteria from the maternal intestine and lumen, internalise these microbes and transport them to the placenta. Maternal diseases such as bacterial vaginosis has an association with intraamniotic infection, an increase in preterm delivery and spontaneous abortion. There is also data to suggest that the placenta itself harbours a low abundance yet metabolically site-specific biome, composed largely of non-pathogenic commensals. Maternal weight can affect an infant's microbiome. There have been recent studies which have observed the composition of fetal meconium in mothers who are obese or have a high BMI during pregnancy, and those that do not. In obese groups, they have higher counts of Bacteroides species and Staphylococcus species, whereas in infants of non-obese mothers, there's a higher prevalence of bifidobacteria count. Furthermore, in diabetic versus non-diabetic mothers, there's a difference in microbes. Many women discuss the use of probiotics during pregnancy, and studies have found that treatment in the third and second semester with Lactobacillus rhamnosus has an increased rate of having a healthy vaginal microbiome, as this particular species has an association with a low vaginal pH. Interestingly, the process of labour can also influence the gut microbiome. Labour involves an endocrine and inflammatory cascade. The increase in circulating cytokines during this process has been found to be associated with an increase in infant gut diversity. Interestingly, microbial diversity is also increased in emergency caesarean sections versus elective caesarean sections, where the process of labour has already started. Vaginal delivery sees an infant's gut microbiome. This review article produced in the University of Western Australia compared the effects of vaginal delivery to Caesar in the neonatal biome. The passage through the birth canal seeds the neonatal microbiome with vaginal bacteria. Vaginal delivery births have higher rates of Lactobacillus species, whereas caesarean delivery births have higher colonisation with Staph and E. coli. It is thought that the vaginal seeding and Lactobacillus species sets up the infant gut to then be colonised by symbiotic bacteria, rich in diversity and density. Another study looked at swabbing neonates with maternal vaginal fluids within 2 minutes after birth. A partial restoration of the microbiota was found for these infants delivered via caesarean section without any swab. However, the long-term outcomes are yet to be evaluated. Infants have also a delayed gut colonisation when they are preterm, those born before 37 weeks gestation. They have immature guts, immune systems, respiratory systems, neurological systems. They have a delay in colonisation with commensal anaerobes and a change in colonisation patterns with Staph and Enterococcus. Interaction between altered premature microbiota and the immature immune system can lead to inflammatory responses and infectious diseases, an increased risk of necrotizing enterocolitis or sepsis. Bacterial use during labour and delivery and postpartum also alters an infant's microbiome. There's a reduction in diversity, an increase in resistant bacteria, mutation in species, and that it does take a significant time to recover. This is amplified with multiple courses of antibiotics, prolonged courses, and broad spectrum. So breastfeeding, it has a profound effect on the development of an infant's gut. 30% of bacteria come from breast milk and 10% from a mother's areola skin. Breast milk contains immune modulating factors such as immunoglobulins, antimicrobial compounds, regulator cytokines, and lymphocytes with gut homing markers. Prebiotics are found in breast milk in the form of human milk oligosaccharides. They promote Bifidobacterium infantis colonisation, block harmful bacteria colonisation as well. This is biomechanism by which the human milk oligosaccharides can bind directly to the bacteria in the gut lumen and cause a conformational change in the bacterial binding sites and prevent binding to cell receptor sites. Human milk oligosaccharides can also bind directly to gut epithelial cells and alter the expression of cell receptors and prevent pathogen binding. So, apart from breast milk and the mode of delivery, how else can we influence an infant and child's microbiome? Diet is a clear example. You are what you eat, so don't be fast, cheap, easy, or fake. The World Health Organization recommends introduction of solids at 6 months, and findings would suggest that it's best if this is done using plants and vegetables in an infant's early diet. It's important to limit meat serving sizes as we serve nutritious meals to our young children, and avoiding processed and packaged foods. High in fat, salt and sugar, these all affect and influence the biome. The biome in developed countries is far different to less developed countries. The quantity of fibre shapes things, even such things as cooking utensils, how food is prepared, can have an effect. There's a lot of talk about probiotics and prebiotics. The wonderful thing about prebiotics is that they can influence the biome by really enhancing and growing good microbes. Really fabulous prebiotic food to include in an infant's diet, things like onion, garlic, apple with the skin on, citrus, leek, can make a big difference. Whereas probiotics are more to be considered like a drop in the ocean. Certainly there can be strain-specific ones which can help ameliorate disease or make an influence, but by and large, the quantity in a probiotic manufactured is far less than the trillions in the microbiome. So I touched on this last time I spoke because I really love talking about feeding little ones, and the point being that it's really important not to give up if you have a child or infant who resists having a vast variety in their diet. And there's a significant number of children in Australia who don't have a good diet for whatever reasons. So how do we change these eating patterns? How do we feed a fussy eater? And I like to categorise this in the types of food eaters there are. There's the I'm full foodie who only likes to eat small volumes when they sit down to a meal. And often it's found that they feel full after a very small amount. Ways to overcome this include providing these kids with really infant calorie and nutrient-dense foods such as ground seeds, porridge, avocado, and avoid unnutritious empty calories. There can be infants who are also quite anxious, fearful foodie. They don't like anything new. Things to think about when you're providing food for these kids can be trying to familiarise them, adding these new foods in by smell, touch, before even thinking about ingestion, and avoid force feeding them or spending hours at the dinner table. There's some children that prefer pureed food, the soft and smooth foodie, and often they are not used to chewing and they much prefer to swallow. Ways to contemplate addressing these issues may be by grating vegetables or adding grains to puree, soft banana or berries to yogurt, and avoiding pouch meals, because this often does not address all the senses that a child develops during that eating process: smell, touch, feel, just by pushing a squeezy out of a pouch. Then there's the infants who are milkaholics. They have a great preference for milk. They find it pleasant and comforting, suckling and soothing. How do you try and overcome this? Well, one idea is as they get older, towards 1 year, to transition them from a bottle to a cup and avoid offering milk first line versus giving them some solids. Finally, there's a dry white foodie, the sort of infant that only likes to eat very bland or white food. And the thinking is that they can be sensitive tasters. To these kids, an option is to add a dipping sauce, melt cheese or add an egg to pasta, and try and put some colourful foods on their plates as well. The key in all of this is to avoid giving up. Diet and nutrition can make an amazing difference to a child's microbiome, and it's well worth the effort in putting in those foods that are going to set your kid up for life. So, as most guts talks include the quote from Hippocrates, all disease begins in the gut. It's so important to care for your kids' guts.